Welcome, everyone, to today's webinar organized by ISSUP Spain on drug use prevention systems and drug policy. We will learn about 3 exciting initiatives that promote universal prevention in drug policy. I'm Livia Edegger, and I'm the Deputy Chief Executive of ISSUP, the International Society of Substance Use Professionals. For those of you who are joining us today for the first time, we are an international membership organization with over 36,000 members who work in prevention, harm reduction, treatment, and recovery support around the world. We aim to provide our members with access to training and credentialing, with opportunities to build networks, share knowledge, and learn from each other's work and experience through our website, locally through our national chapters, and through our events. And I hope that you will all join us in beautiful Thessaloniki in June at this year's ISSUP and ICDDR joint event organized by ISSUP Greece and local and international partners. Natalia from ISSUP Greece, who is here with us today, can provide you with more information on that. And if you're interested in joining us in Greece, you can register for the event on our website. As always, at the end of today's presentations, there will be a Q&A session. You can send us your questions through the chat function on the GoToWebinar control panel. We will try our best to address as many questions as possible during the Q&A session. And today's webinar is available in English and Spanish. So please follow the instructions in the GoToWebinar chat. I will now provide our Spanish-speaking members with the interpretation access information. Muy buenas tardes a todas y todos. Me gustaría...
Good morning, everybody. I would like to announce that today's webinar is available in Spanish. Please go to the chat at GoToWebinars, where you will find the instructions to have access to the webinar in Spanish. I hope you enjoy this webinar and that this information is for your benefit.
The recording will be available on our website and our YouTube channel. And just a quick reminder that the webinars hosted by ISSUP are provided for informational purposes only. They are educational in nature and do not constitute medical advice, diagnosis, or treatment. On behalf of ISSUP Global, I would like to thank our national chapter in Spain for organizing today's webinar. I would like to thank today's esteemed speakers for their participation. And of course, thanks to everyone who has connected. Without further ado, I will now hand over to Uther from ISSUP Spain.
Thank you very much, Livia. We're very happy to organize this webinar, and we wanted to start by welcoming all those attendees that have joined to this webinar. It's more than 970 registrations. So this is speaks about the interest on prevention to try to modify those elements, those factors to avoid problems in drug use as much as possible. And this makes us really happy. And this is, of course, the result of an effort to continue to work to get better evidence for our actions. And today we will have the opportunity to get to know several experiences with our speakers. Also from Spain, from the Spanish chapter, we would wanted to thank Livia and the whole global team for giving us this opportunity, this technical support for us to have this webinar. As Livia said, we are comprised of more than 20,000 members around the world, and out of this interest for prevention, and from the different corners of this planet, gives us strength to continue to work on this endeavor. We hope you can be with us during these 90 minutes. As Livia said, we are going to speak about 3 different experiences. Each one is going to take 20 minutes, and at the end, we're going to have 20 minutes for questions. And on the upper right corner, you're going to be able to ask your questions, to which we'll try to provide a response at the end of a webinar. Without further ado, I would like to pass it to Victor Villanueva, our partner colleague in Spain for presenting, for announcing the talks for today and our speakers. Thank you very much. And thank you, Livia, for your intro and the whole ISSUP family, not only for organizing, but for this significant number of attendees. And this speaks of the influence of ISSUP in the world, and also speaks of the quality of the talks that are lined up, as we've presented. From Spain, we've proposed this webinar with 3 talks with 5 speakers. I'm going to introduce each of them, and then we'll introduce each talk individually. We have Wadih Maalouf from Austria. Wadih is a leader of the prevention program and treatment and rehabilitation of the United Nations Office for the Drug and Crime. He's got vast experience in the reduction of the amount of drugs, and he's a specialist of mental health. But the public school, Job Hopkins, is also a coordinator of his center, which is what he's going to be talking about today. In Spain, we have Rio Squidis, international delegate of the United Nations project inside the European Union and other international bodies. He's been doing prevention from drugs and addictions for more than 27 years. And currently, he coordinates the Global Society for the Prevention of the Use of Drugs. We'll also have Natalia Fasorse from Greece, director of SEDIOS, a network of organizations for prevention. I remember this year there's the ISSUP event. So I encourage everybody to come visit the ISSUP website and find information. She's a coordinator of ISSUP in Greece. She's a co-organizer of this World Congress that we're going to be having next June, and member of the task force for the Global Initiative for the Prevention of Drug Use. And from Norway, and related to the initiative that was presented, we have Yvonne, Larsen, and Alexander. Yvonne Larsen is the Vice President and Coordinator specialized in public health, more than 30 years experience in work in institutions, schools, and children's drug use prevention, and she's got a vast experience in prevention of addictions and public health. Alexandra Soli is a psychologist. He is experienced in clinical projects with addictions and mental health, especially in children and youth at the municipal level, as well as the mapping of resources and evaluation of different interventions. Without further ado, we're going to now give the floor to Wadih Maalouf, who's going to talk about the initiative on CHAMS, whose objective is to talk about the children path from early childhood and their evolution, the use of drugs, and the results that could be affecting the vulnerability these children face along their life. So now we give the floor to the first speaker.
Thank you, everyone, and I really thank ISSUP for organizing this event, particularly the ISSUP chapter in Spain for picking this specific topic. And I hope you can see my slides. I would try to just start by giving a general overview of the system of prevention and how it led to a new initiative that UNODC is undertaking why there is a system of prevention. But I'm very happy to see that on the agenda there is going to be 2 additional presentations that will, one, dwell into more details on the review of the prevention system, 2, that I will talk about, and 2, talk about the civil society's interest in terms of pushing an agenda of having a system of prevention that the Oviedo Declaration will refer to. At the outset, it's important to remind that for UNODC, our campaign, our activities that we are striving to through our World Drug Day that happens on June 26th, the latest campaign has this slogan in front of you, people first, having a people-centered approach. And it has a subtitle to it called Stop Stigma and Discrimination and Strengthen Prevention. These are essential things that, we're pushing for as an agenda moving forward, really in the context of addressing drugs, to shift the point of focus from the drug to the people, to see how we can support having a person-centered approach, and how that person-centered approach will stop stigma and discrimination, and how prevention kind of supports this. Generally speaking, as an objective of our work, I'm coordinating the global program on prevention from Vienna, but we have our field offices on the ground actually programming and engaging with the direct counterparts on prevention. Our work as a global program is to support the policy making as well as the tools related to engage on policy making to change the culture of how prevention of drug use is happening. That change of culture is supported by, first of all, really reflecting the science, the culture of science that exists within prevention. And here you will see the international standards on drug use prevention, where we have applied the scientific evidence per WHO standards of evidence. So that's a joint UNODC WHO standards of prevention. There is a lot of science behind the work. The culture of implementation, meaning that it's not only the evidence-based tools and the policy making that is important, but how things are being implemented, with what qualifications are being implemented on the ground to avail that science to the recipients, and the culture of research to generate more and more monitoring and evaluation of the fidelity of the implementation of evidence-based programs, as well of new innovative programs that were not in existence or has not been documented to be transferred to that knowledge. If you see that, the prevention standard reflects a large spectrum of activities, because this is related to the person-centered approach, where prevention responses in line with the WHO standards of evidence are reflecting to be effective as early as when the child is born, or even within the fetal period when the child is in the embryo of the pregnant mother. And every age of development has different support structures, from the family to the school to the community that can help that child. And every age of development require a different milestone of achievement to pass to the next level, meaning that there is not a one-size-fits-all response, but every age require a different sort of assistance. What you will see also that there are some interventions that are universal, meaning that regardless of the level of risk, that's in green, any person at that age would benefit from it. There are some interventions that are more selective in prevention, meaning that these are for a population that might have a higher level of risk compared to the general population. You see it in yellow. And then you will have also indicated prevention, meaning for individuals that have certain symptoms that need to be addressed before they escalate into something more problematic. So needless to say, that shift to a person-based approach to a developmental approach has been advocated for strongly in the prevention standards for policymakers, and it has changed the way policymakers are thinking about how to address the response. That recognition of the science have been very well articulated in the general policy agenda of member state of the United Nations, as you will see from the General Assembly special session that happened in 2016, where a joint commitment on addressing the drug problem was put in place, and addressing and having prevention as a component of the response in line with the standards was well articulated. but also and as well in the Commission on Narcotic Drugs, which is the body of the General Assembly that meets in Vienna on the Commission on Narcotic Drugs, that has always been echoed as a political declaration, but even regional strategies now in big regional bodies. Since we are in Spain now, the EU drug strategy also reflects the importance of placing standards moving forward. With that knowledge in terms of changing the culture and that we know what works at what age of development, the issues that are at heart of our work now moving forward are the fact that because it's a developmental approach, we want more services that are starting at earlier ages of development. And we have evidence that the earlier you start, the better the outcome, not only on drug use, because you're focusing now on the person at early stage of development, but the outcome not only on drug use, but on other outcomes that share a similar vulnerability. This is an example where children in a certain community in the United States received a preparatory program in kindergarten to get prepared to school, living in a community where there is social inequalities. So in blue, you see the group that took a program that prepared them to go to school, the intervention group. In red, you will see a control group from the same community that randomly did not take that program. They just were prepared to go to school. And they were followed until the age of 21. And you will see the group that was just prepared to go to school had a lesser level of marijuana use during the last month, current marijuana use, compared to the red group. But also that same intervention helped reduce the number of teenage parents and increase the number of people enrolled in college, the blue group as compared to the red group. So early prevention is something that is key. Another component that is important is the fact that, yes, there is evidence-based programs that come at different level, as I discussed on the prevention standard, but one program does not necessarily replace the effect of the other. The more programs you have, the higher the effect, a multiplicative effect of prevention. That's another slide that showcases a group of three categories of students that come from the same community, followed from 6th grade in school up to 12th grade, in a setting where the misuse of prescription opioids for non-medical reasons is high. And these three subgroups were divided into a group in gray that was followed up and received normal services, a group in green, mustard green, that received a life and social skills program, and a third group that did receive this life and social skills program, that's in mustard, but additionally received family skills program. And you will see when you add levels of prevention, that effect becomes multiplicative, meaning more and more services have more and more effect of prevention. A third body of evidence we have, the slide might be very complicated, but I will simplify it and you'll see the link where you can go into more details on ISSUP on that study, that even if you have within a school setting applied an evidence-based program, in this situation, if I remember well, the program is Unplugged, which is a life and social skills program, a school-based program for early adolescents that build life and social skills. And they compared a group of schools that the teachers were actually trained on this program to another group of schools where the teachers were also trained on the program, but over and beyond being trained on the program, they were trained on the context of the science of prevention of drug use in a school setting, the larger context of it. So the environment of the school, the climate of the school has improved, and that this body of school had an amplified effect, a higher level of effect of the same program when applied in such setting as compared to a setting where the teachers were only trained on the program. Meaning that the context where the program is applied is also important. So as a system, the system requires two elements. Yes, at the base, you need evidence-based programs or policies, but the supportive system that produces and kind of provides these programs is also important. And it is the value of both that provides an effective prevention. And this is where we were moving to systematizing, have systems of prevention in place as the new modality that we're pushing through. Now, in our prevention standards, there is a chapter from 2018 that mentions that how that prevention system should look like theoretically. At its base, you need evidence-based programs, as you see. In Europe, you will have, for example, the exchange database of EMCDDA, EUDA in the near future. But also, when you apply these interventions, you need arrangement stakeholders applied in the planning, a strong delivery infrastructure that, the funding, the human resource capacity building, the laws and legislations that facilitates the implementation of these programs, and also at the local level, a coordination between these. So that system has been already in the prevention standard for a long time. But what we have done now is provide the member states, the stakeholders that are interested in this system, with a new tool called the review of the prevention system, where these policymakers, these stakeholders, can map out the services that they have and reflect through a SWOT analysis how these services map out in comparison with what the standards reflect, including on age groups and level of vulnerabilities. I will not dwell into the details of these because you will hear them more from Yvonne and Alex later on, but this is systematically how these things are being reflected. Just picking every single intervention and mapping out to see what you have as responses. But not only the responses, also the level of how much the system has a comprehensive level of services, the delivery structure that exists, the regulations that exist, how much research exists, how much coordination, how much sustainability. All of these are mapped out in terms of identifying gaps moving forward. So this system approach that we're trying to provide the tools to make it happen are key. And that tool, the REPS that you will hear about, is an important tool that support more in-depth SWOT analysis, going beyond just like, this is the epidemiological situation, but when it comes to services, how do we rate the services that deal with this situation? This is a tool that helps policymakers further strengthen how they want to move forward and what resources they need to apply to fill the gaps and what resources maybe are overburdened on a system on services that are not necessarily as effective to meet the needs of the prevention. It highlights interventions as well that are not previously accounted for in a national strategy, because now we're talking about the development of children. It orients national plans of action and strategy with better decision-making processes. You feel more confident investing in these activities. It improves the investment of resources in a more appropriate way, more priority-oriented way. And it advocates for streamlining and coordination between the entities of the response. But also, it's an incentive for people providing these services to research and document their effectiveness, to map themselves out in the system, in the REPS module, in the decision-making process, and incentivize actually also availing resources for research and monitoring and evaluation moving forward. So it has multiple purposes. And you will see from the experience of Norway later on how much this is important. Now, all of this introduction is on the tools, the political commitment, the scientific services, the scientific knowledge that exists to justify a system. There remains a big question on, do we have models of systems that have been applied on a large population base that kind of reflected a change in the developmental pathways of children? And this is where UNODC have, put in place this program, CHAMPS, the Children Amplified Prevention Services. This QR code will take you to the webpage on our UNODC website that details more than what I'm going to describe on CHAMPS. But what it is, in a nutshell, is calling for a group of countries to model such a system. You will see on horizontally, you will see school-based survey, monitoring and evaluation, the core component of a strategy development, let's say within a geographical location. When I say children, I'm talking about children within the legal age of definition of children, less than 18. Less than 18, all the children that are less than 18 within a specific geographical area. First of all, what we do usually in terms of availing services, assess the drug situation, what kind of substances are used, not used, mode of use. But what you will have horizontally is a mapping of the system of the services that are availed at different age of development. During pregnancy, up to 6 years, 6 to 10 years, 11 to 14, and 14 to 18, in groups of children at 3 different levels. At the universal level, because any child at a certain age would benefit from certain services in line with the UNODC WHO standards, but all that's in green. In yellow, you will see the services that are selective. What about the children that are living at higher level of risk as compared to the other children, and what services they need in different ages of development. And in red, you will see the line of children that have indicated level of prevention, for children that have a certain symptom that need to be addressed before it escalates into something more. So we will map up through a 1 + 5 year process, meaning the first year is a year where we will assess the situation, review of our prevention system, agree on what indicators need to be used, because we need to apply this system over a period of 5 years. So 5 years later, the 4 to 18 would move to the age of 19 to 23, meaning they will move to an age where substance use might occur. And we will assess how this system over that period of 5 years have prevented substance use within this population. However, there's a large group of these children that have not moved to this age of substance use, where we will work also with the countries that are CHAMPS countries to reflect on other indicators with the common level of vulnerability that is linked to substance use. That same vulnerability is linked to mental health, to school dropout, to violence in schools, youth-based violence, and other sort of negative and social outcomes, where we will monitor the needle change across these different indicators of work. For policymakers to be encouraged to see that this investment in this modality, that is person-focused, to go back to the beginning, is not only effective to prevent drug use, but has a return of investment going beyond drug use prevention and supporting more than one sustainable development goal for the country involved. So I hope with this general introduction, you will see the value of the importance that we are placing on systematic approach of systems application of prevention, and how we're introducing a new tool that really, a new initiative that really invites championing such systems in different locations. We will try to network as many of these systems as possible with each other, reaching a large group of children within these 5 year spans, and hopefully incite more and more countries to invest in evidence-based prevention for the health and welfare of children. I will stop here within the time allotted for me, but happy to answer any questions later on and pass the floor back to the organizers.
Muchas gracias.
Thank you very much, Wadih, for your presentation. Now, for the sake of time, this is one of the most difficult things when we're trying to explain our projects. Now, let's move to the next presentation. We're going to have a time at the end for questions and answers. So you can drop your questions in the question panel. We'll pick them up at the end. Thank you for your patience. Now let's go to the next presentation. Here we have Natalia and Eros. They are going to present the Oviedo presentation promoted by the civil society. And without further ado, I'll pass it to Rola for them to explain this whole global movement, to tell us more about how it is going.
Thank you so much. Well, thank you very much, ISSUP Spain, also ISSUP globally, all speakers, Wadih, colleagues, all of you attending this great webinar. I think this is a great opportunity to present the global initiative on drug use prevention with the Declaration of Oviedo, which contains 10 proposals to incorporate evidence-based prevention more effectively in drug policy. It is an initiative officially starting in January this year that has been growing and growing, involving many organizations around the world. The main purpose is to bring together and coordinate the need and demand that already exists to scale up drug use prevention after decades of drug-related problems. And you can see, and also after hearing the great Wadih's presentation, that it seems to be the momentum. It was born, next please. Next slide, please. Thank you. It was born in an expert consultation in the wonderful city of Oviedo, Spain. You can see also Wadih Maalouf that was joining. Next, please. After that, we set up a task force of committed people from the 5 continents, action-oriented or leaders in the region. Next, please. I'll try to be fast. Before starting, we took months of intense work with prevention experts all over the world to elaborate a declaration that had to be concrete, short but meaningful, and also widely accepted by all cultures. Next, please. And surely one of the main strengths has been what we have called country focal points, reliable organizations that are the link in each country, providing local and national knowledge and promoting the declaration, the initiative, an informal network connecting what is a global initiative with the field. By the way, we are still looking for focal points in some countries. Next, please. Likewise, it is essential that the document is translated into many languages so that it is more accessible to the local populations, and we continue to translate into more languages. Next, please. This is just an overview. 1,100 supporting organizations from 100 countries already. You can see the distribution on the map. You can also see your own country. Those countries with more support can now approach to their governments to advocate for better and more prevention. For the task force, it is a priority to reach out to countries where the initiative has not yet started. Next, please. Spain, the United Nations Office on Drugs and Crime, the Council of Europe, the University of Balearic Islands, the University of Oviedo, and the Vienna NGO Committee are observers of the process, which is very important. And you can see the website oviedodeclaration.org. You can access all information, the whole text of the declaration in your language, and please contact us anytime, task force. Hopefully you can also endorse the declaration if you haven't done it yet. It's very easy, just 20 seconds at the website oviedodeclaration.org. Next, please. The initiative was launched last month at the United Nations Commission on Narcotic Drugs with more than 20 activities. It was very exciting. Next, please. And among all of them, next, please. Yes, I would like to highlight the meeting. No, the other one, sorry. Go back, yes, thank you. I would like to highlight the meeting with Her Excellency Fatih Wali, which is the Executive Director of UNODC, who received a delegation of task force, but we did a lot of hearings, also presentations, side events to promote the initiative in the margins of the CND. And now, just was very brief introduction of what we have been done all this month. I would love to pass the floor to Natalia, one of the great experts in prevention, super involved, who will be presenting the 10 proposals of the declaration. Next, please.
Hello, and welcome. Thank you so much for having us. Thank you, ISSUP Spain. Thank you, ISSUP in general. So I'm going to outline the 10 proposals that we have on the Declaration of Oviedo. Number 1 is we call for countries to dedicate at least 25% of their drug demand reduction strategy and policy budget on prevention by 2030. Considering the existing evidence on effective and cost-effective prevention, we urge the countries to achieve a national consensus by 2030, committing to allocate and sustain at least a quarter of the total drug demand policy budget to drug prevention. Furthermore, we reiterate that policies should be proportionately balanced between drug demand and drug supply reduction measures, whilst ensuring public health and safety for all individuals and guaranteeing their human rights. Next, please. Number 2, promote an approach to prevention targeting all ages of development and favoring earlier prevention. Prevention should start at an early age, as early as possible, to be honest, and consider the period starting from pregnancy, neonatal, childhood, and adolescence by identifying priority family, school, and community as intervention areas, and continuing prevention interventions in adulthood. Effective prevention focuses on strengthening the protective factors and empowering individuals throughout their lives on personal, emotional, and social levels. Number 3, next slide, please. Foster research and evaluation to avoid ineffective and counterproductive prevention strategies. Prevention is a science. As such, formulating and implementing prevention policies should incorporate evidence-based and data-driven interventions and systematic assessment mechanisms guided by international standards in strong collaboration with academia and civil society organizations. This approach is essential to refrain from drug policies based on misconceptions and misbeliefs, and furthermore, we need to invest in research. Research is of very high importance in order to ensure the implementation of effective prevention interventions and in different social, economic, political, and cultural contexts. Next slide, please. Broaden the vision of prevention responses to shift the focus from drugs to the individual and the community. By focusing on the person rather than the drugs, preventive interventions take into consideration vulnerabilities at the individual level and the potential protective effect of the social structures and the legislative framework surrounding the person. This approach prevents not only the use of illicit drugs, but all drugs in general, including tobacco, alcohol, prescription drugs, cannabis, new synthetic substances that are highly prevalent. This would also encompass prevention of non-substance addictions, such as gambling, digital gambling disorders, etc., what we call behavioral addictions. Next slide, please. Mainstream intersectional approaches in prevention for all populations at risk. The impact of drug use is inequitable and highly dependent on social determinants of health that are influenced by several factors, including identities relating to gender, ethnicity, age, race, sexual orientation, location of residence, amongst other factors. Therefore, prevention strategies must incorporate a holistic intersectional approach that addresses different vulnerabilities and allows for the establishment of more equitable and fair policies. Prevention services should make all efforts to cover and prioritize the most excluded and marginalized and stigmatized groups, such as the unaccompanied minors, houseless people, people that suffer from mental health disorders, migrants, displaced populations, and other groups. This would require prevention responses that are tailored to the specific and individual needs of each person in each context. Next slide, please. Boost multi-stakeholder prevention systems and documenting effectiveness and cost-effectiveness when implemented globally. The systems of prevention should bring together diverse measures and coordinated efforts from multiple governmental, non-governmental, and community-based sectors that provide services at scale for children, youth at different ages and different developmental stages. So the countries should benefit from available prevention services at national and local levels when aligning them to international scientific standards. Therefore, more should be interested to replicate prevention models that have proven their effectiveness and cost effectiveness at an international level. Next slide, please. To provide universal coverage and a continuum of care. In line with a public health approach, countries should provide drug prevention that is accessible and affordable for all individuals everywhere, globally and locally. And we need to provide, to promote early detection and intervention, harm reduction, addiction treatment, recovery, and social integration in a logic of a continuum of care. Next slide, please. Prioritize action in low and middle income countries. Low and middle income countries and regions experiencing humanitarian crisis, basic social and healthcare infrastructure may be lacking. So in this context, investing in prevention should be the key priority. We encourage building strong partnerships between governments, international organizations, civil society, and the private sector, as well as prevention experience exchanges and contextualizing and localizing prevention strategies based on a do no harm approach. We also encourage implementing initiatives to empower families and other caregivers, youth-based and community-based leaders. Next slide, please. Empower current and future generations of prevention professionals. Recognizing the key role of professionals in implementing effective prevention, we urge the educational community to incorporate the science of prevention of risk behaviors in core and compulsory curricula of health education and social science teaching. We also stress the need to provide certification processes and continuous training for prevention practitioners throughout their working careers and ensure that we provide the supportive conditions to avoid burnout for this specific population. Next slide, please. Monitor the status of prevention policies throughout accountable surveillance. We invite countries, the Commission of Narcotic Drugs, the United Nations Office on Drugs and Crime, the World Health Organization, and related organizations to adequately assess the coverage, relevance, implementation, investment, and effectiveness of drug prevention policies in their jurisdictions through ongoing surveillance and data reporting systems of international, regional, national, and local monitoring drug reports, or by establishing an ad hoc monitoring in solid collaboration with civil society. So if you are in accordance with this declaration, we have to tell you that we need you. The more we are, the strongest our voice to advocate for effective and cost-effective prevention. Next slide, please. So if you want to join, please do not hesitate to click on www.oviedodeclaration.org. And here are some of our upcoming events: the virtual regional hearings on drug use prevention. The Americas hearing is on the 14th of May, the Asian Pacific hearing on June 4th, Africa hearing on July 3rd, and the Europe hearing on September 6th. Thank you so much.
Go ahead and present that last presentation. There we have Yvonne Larsen and Alexander Hvaring presenting the REPS project for the prevention review system and their experience they have in Oslo, a more specific experience for the municipal level. So here we give the floor to our partners.
Thank you very much for having you, ISSUP and ISSUP Spain, and thank you for your presentations, Wadih and Oviedo. We are really looking forward to hearing more about that later. But now we are here we are invited to present, as Wadih told us earlier, that we have had this pilot in Norway of the review of the prevention systems called REPS. And we are here today to tell you something more about that. And this is the agenda. We have 20 minutes and we will share this presentation. And of course, we are available for questions later. So we will start with that, telling you who we are. We are Chorus Oslo, so we will talk a bit about that because that's crucial for the REPS. We will talk more about REPS. We have already had a presentation from Wadih, so we will not talk so much about it, but something. But the main purpose is to tell you how we adapted REPS to the Norwegian context and how we collected the data and what we learned about our prevention work in Norway after this pilot and how we will use it in the future work. So this is us, as you can see, with a bit more happy photo than we are now in the dull office. We are Chorus Oslo, and we are one of 7 regional competence centers on drug and alcohol in Norway, working with the substance use prevention, early intervention, and treatment. And we work from the entire life course, from the prenatal phase until death, really. So we're covering everything. And in 7 regions of Norway, we will show you the map later. We are funded by the Norwegian Directorate of Health, and we are also working on the behalf of the Directorate of Health. They are giving us kind of the mandate and the strategies how we should work from year to year. And we are a very small population in Norway. We are 5 million, so that's also important to know when we're talking about the context. And Oslo itself, the capital of Norway, has about 750,000 inhabitants. So this is quite small, I guess, compared to most of the other countries representing here. So what this is the UNODC and WHO's international standards on drug use prevention, and I don't think we need to go deeper into that at this point because Wadih already told us the whole story. And he also introduced a tool and how we can assess the prevention initiatives. So, as he said, this is a tool. The review of prevention systems, the REPS, is a tool for assessing prevention initiatives, alignment with the UNODC WHO international standards of drug use prevention. And it is both at the systemic level and at the specific initiative levels. And the aim of the review is to enhance the international prevention efforts. And it's designed, as Wadih also said, to promote evidence-based drug use prevention. The pilot in Norway was took place from 2022 to 2023. And I will say something more about the process in a bit. But we had 2 main questions. It was, what is the situation in Norway? And these questions, they were given by the Ministry of Health and Care. And can you adequately assess a country's prevention efforts using this tool? So the initiative from this work and also the financial side came from the Norwegian Ministry of Health and Care Service. And in August 2022, we established the review committee with the UNODC and ourselves and the Ministry of Health and Care Service. And we were actually asked by the Chorus Oslo, myself and my colleagues, we were asked by the Ministry of Health if we knew any relevant project staff that could assist UNODC to collect the data in Norway, because they were going to run the whole pilot. And quite quickly we realized that this was extremely relevant for the work we are doing as choruses and working with prevention work all over the country. So we joined in, and this has been a really great travel. We had the official kickoff in Oslo in September 28th in 2022. At the conference Alcohol and Drug Prevention in the Nordic countries. It was arranged by the Nordic Council of Ministers. And then UNODC and all choruses and the ministry were represented, and we were having this kind of kickoff meeting to start the work and actually work of the pilot. In October, we translated and digitalized the Annex 2. We will tell you more about the Annex and the questionnaires later. The Annex 2 is a questionnaire. And because we realized we had to translate it to, even if most of the Norwegian professionals and people are speaking very well English, it was necessary, and also to contextualize it. We did the test questionnaire in November and December, and we had a few practitioners working in outreach work and social workers, etc. They were testing it with us. And in January, we, as I told you, we are seven courses, but not everybody had the time and resources to join as much as some of us. So we were 4 courses boarding in this operation and mission from January. And the data collection itself was from February to May, and in June until September, we did analysis, we translated it, we gave supplementary information and contextualization in the review committee. And actually, I think we finished the actual report only a couple of days before we had the official launch of the report of the pilot in the Ministry of Health and Care Service, September 28th in 2023. So this was carried out exactly within 1 year's time. So that's the process. And this is a map of Norway, not a real map, but our map we use in the chorus. This is the chorus map, but it shows the whole country and the geographical sides of the regionals. So we have 4 of these courses represented, but we do work very close to with all the courses. So we think that the data collection is more or less representative, but then that Alexander will share with you in a moment, because I guess you are very curious to see what we have collected of data and what the pilot said.
Yeah. So the data collection was done via 2 different components, and these components reflected 2 the systemic assessment, and the strategy level assessment. The systemic assessment, called Annex 4, was facilitated by the Norwegian Ministry of Health, and was a questionnaire sent to the different ministries and other relevant parties. And the Annex 2 was the let's say strategy level assessment. So that's where we assessed the existing prevention strategies in Norway, asking ourselves, are these evidence-based and are there characteristics associated with effective prevention? And we're prioritized speaking about the Annex 2 strategies now, as that's mainly what we worked on in the review committee. But the Annex 4 assessment is described in the report, which is available online. I guess it's it's not the final report, but it's available still. Yeah. So Annex 2 questionnaire, we asked specifically what's done. So what is the initiative? Who is the target group? Where is it done? Both what setting is this done in and in what region geographically? We asked why it's done and whether or not it had been evaluated. And when we say evaluated, we're talking about effect evaluation. So the outcome variable here is drug use or substance use behavior. So have you found a reduction in substance use, basically, would be the successful outcome. All the respondents were able to upload documentation regarding evaluation, or if there were handbooks or different strategy documents and so on. So there was no real limitation on that. So we encouraged them to upload as much relevant information as possible. In some cases, we even reached out to them to ask for more, or in several cases actually, we reached out to ask for more information if things were unclear. The questionnaire was distributed to key persons in each region, and this is where, as was mentioned, this structure of the courses is important, because we had people in every region who had a good overview of what's being done and who is responsible for different initiatives. So we could recruit key personnel to answer this questionnaire. And we distributed 99 questionnaires and got a 81% response rate. Out of those 87 answered questionnaires, we had 187 unique reports, which after screening was reduced to 130. And during the screening process, we had to eliminate, for example, reports that didn't have enough information, or strategies that were treatment rather than prevention, things that weren't really started yet, and some things that were part of larger implementation structures. And so some of these excluded reports were included in the Annex 4 assessment rather than the Annex 2 assessment. We brought some graphs from the assessment just to illustrate what sort of outcome you can get from doing this review, what sorts of output you can get. So here you see the strategies categorized by target group age in Norway. And interesting to note here is that the majority of strategies target adolescents and young adults. You can separate the strategies by risk level, and this kind of goes along with the former slide, because a lot of these universal strategies are targeting adolescents and youth and children at their school age, or their parents. These multi-level component intervention, or these multi-level category consists of a few interventions that are have several components that target groups at different levels of risks, and where the components weren't really, we couldn't really separate them into separate interventions. Here you see strategies by setting. We have every setting covered in Norway, quite a few multi-setting strategies as well. And it's important to note here that a low number doesn't necessarily mean low coverage, because some of these are nationwide interventions and they still are reported as only one intervention. This is particularly true for the workplace interventions. And here you see the strategies characterized by quality. And it was interesting to see that we have a lot of supporting services in Norway. And by supporting services, these are the things that aren't included in the standards as effective substance prevention interventions, but they contribute to the overall health and resilience of children, youth, and adults. So this is on a national level, all the strategies categorized by quality, and by quality, of course, we mean to what degree are they evidence-based or in line with the characteristics of the standards. Just one more example, adding yet another variable. So now you can see the strategies by quality and setting, and this way you can get very precise information about the different prevention efforts you're doing in what settings, what age groups, and so on, and to what degree are these evidence-based. And there you can find gaps in the total prevention efforts that you can improve. And you see here what I was mentioning earlier about these universal strategies targeting school age. Typically, this would be like a drug preventative education for school age adolescents and stuff. That's not really in line with the characteristics of effective prevention. So what did we learn doing this pilot? That could be nice to know for people who may want to try to do the same. One thing is having some sort of coordinating structure that resembles the one we had as the courses, because it was very important, we think, to have people with the right competence that are close to the service providers and with knowledge of the existing efforts at all the regional levels as well as national levels. We think this was vital to getting what we think is a representative image of the prevention efforts. We included representatives of potential respondents in the adaptation and the testing of the questionnaire, and we maintained dialogue with them both before and during the collection and analysis. Which Yvonne mentioned, we translated and digitalized the questionnaire, and we just think that's an absolute necessity. And our regional operatives reiterated that a few times, that this wouldn't have been possible if we used this paper questionnaire that we were planning on doing. We also think it's important to have local representatives in the review committee. Like Yvonne and I was for this pilot, in order to translate. Let's see. This probably shows up on your screen as well. A bit late for that, but to translate, to supplement, to contextualize information, and just general quality control from a local perspective. We had weekly working meetings with Wadih and Giovanna, going through each and every response to ensure that we had understood the information correctly and that we had enough information. And finally, you want to wrap it up?
We wrap it up. So what now? We have, as we already have said, we have gained a greater awareness of the strength and weakness of drug and alcohol prevention in Norway. And even if this review shows that we are doing a lot of good and important work, we need to do more and more of a lot of it, and to strengthen some of it. And there is also a need of improvement, especially when it comes to the interventions and some of the main conclusions regarding the interventions at the local level. More than a third of interventions were reported to be non-evidence-based, and this is an obvious opportunity for improvement. So we have to identify what might be the most appropriate mechanism to ensure an increase in the adoption of evidence-based interventions locally. And we need to evaluate the effectiveness of intervention and policies. The strategy providers are curious about the results and motivated for use effective strategies. This is also has been a great opportunity for us to make a national effort for the courses to promote and to implement European prevention curriculum from EMCDDA. So that will be translated into Norwegian. And also the Directorate of Health have decided to translate the report from this pilot into Norwegian as well. Because people are really interesting and they want to improve and to enhance the work. So, and we're also very curious about the global work. So we will. So this will be, and we hope we can contribute with our experience to the further development of the tool and implementation of the reps. So I think this is our contact information. So if you need to be in touch, don't hesitate.
We noticed that the Oviedo declaration wasn't translated into Norwegian, so we think we will see if we can get that done while we're translating this other stuff.
So we can do it all in one.
Wonderful, wonderful.
Thank you.
Thank you very much.
Muchas gracias.
Thank you very much for your presentation. This is a costly effort, but is necessary for our interventions to work. We've received a few questions. We have 20 minutes. And thank you to all the speakers for sticking to the agenda and to the time allotted. We have received questions from many parts of the world, from Egypt, from Argentina, from Mexico, from South Korea, from Nepal. A very specific question, Ariel. This is sent by Sirhana Tata from Nepal. They want to adhere to the Declaration of Oviedo. They're asking if there is any entity, any focal point, any where in Nepal they can go to.
Yes, there's a Nepali contact. There we have a focal point there, but I would suggest that I will write my email address at the chat box, or if anyone can do so, they can just reach out to me and I will give them precise details of what is going on prevention there, but also the person and the organization that is the focal point for Nepal. So thank you very much for your interest.
Gracias, Oriol, por la aclaración.
Thank you, Real, for that clarification, Ernesto. Also, thank you for the declaration of Oviedo, especially to face those situations in the work setting. And another question for Wadih. From Argentina, Javier Cordova from Argentina, he's asking, in terms of the evolution of the knowledge on prevention strategies and specifically the changes in policies and interventions through artificial intelligence, included telehealth tools. Do you have any recommendations, if there's any, about the integration of these tools in community settings and school settings?
Thank you very much.
Thank you very much. Thank you.
I hope you can hear me now. Apologies. Yes and no. The thing is, what we are doing is exploring more how to integrate artificial intelligence in the context of prevention. And we do have planning to work actually with the tech industry in general to see how we can integrate and how we can capitalize on the positive side of, let's say, of technology when it comes to prevention. It is clear that skill building exercises are benefit more from in-person reactivity and action. But that does not dismiss the fact that we could generate more data on how we can move that in-person skill building activity to let's say, an interactive digital forum that can build skills. And the other element is what kind of skills can be transferred. Maybe not all the skills, some of them, particularly when it comes to normative belief, critical thinking, what activities of prevention can be transferred. I think this is work in progress where the research is not conclusive, but the presence of these new tools at place warrants the fact that we need to research more how to benefit from such platforms advised.
Muchísimas gracias.
Thanks a lot, Wadih. I want to ask you a question from Barcelona. That is myself. In one of the first slides you presented, you said that for every age we have a set of actions and strategies, specific actions for each age. And from the United Nations, maybe you have a more global vision if these strategies can be globalized, or every country, depending on the age, should have different strategies. That is, for example, from 14 to 16 years old, for example, in Nepal, is it the same as the strategies we should be developing in the US or in Norway?
This is a very important question, and yes, there is the age developmental approach is the key component. Now, there might be differences in the age of maturity in different contexts, depending on developmental issue. Fine, that might occur, but there remains the fact every age of development requires a specific milestones of support. So the science itself is universal. Okay, what is a child that cannot communicate at this time? For example, let's say from birth onward. Let's not say that to a specific age. A child cannot speak yet, but is communicating through crying, to smiling, to this. What sort of interactive modality? A child is communicating and is not in school yet, requires certain milestones of development to prepare that child to understand their emotions, the emotions of others. A child that began in school, that early school years, without looking at the categorical value of the age. I'm talking in terms of the milestone of development of the child. First time to go to school requires certain milestones of how to build a relationship with others, how to recognize their own feelings, the feelings of others, how to stop, and then when you go to early adolescence. So these are, when you see it from that person-centered approach rather from the age-specific approach, that developmental approach is universal, and the tools to support that age of development exist. How the tool is going to be implemented might require some cultural adaptation. But yes, that science is a universal science. And we really encourage more and more research of this evidence-based practice being transferred, and that transferability, how it's applied, being documented.
Muchísimas gracias.
Thanks a lot. Wadih, we have two questions for chorus. They're asking if you mapped out the private and public interventions and how they reached their respondents. And another question is, can you talk about some of the examples of support services?
So the first question was whether or not we mapped out private and public interventions, right?
Yeah. And we yes, we did. We did. We have a lot of public services, especially when it comes to the local municipality work in Norway. But we also have some NGOs working throughout the whole country, like Red Cross, Blue Cross, etc. Especially targeting the young people. When it comes to the adult population, we have several NGOs, but for the children and youth, not so many. But we did, yes. And when it comes to the supporting services, will you give some examples?
Yeah, I was trying to think of a specific one. I can't really come up with a concrete one, but in general, these are the services that are so rather than being specifically targeted towards substance use prevention, they are more on the, like, what would you call it, like salutogenetic side, so more on the improving the resilience and life.
General promoting healthcare and
just overall health and resilience. I think is the keyword. Did we describe, or do you remember, Wadih, if we had described in the report some specific examples?
Specific examples
of supporting.
I'm sorry.
I don't think we described anything in the report.
No, I mean, the specific, I think in the report kind of condenses all the information rather than just go into specific initiatives. Yeah. But, the mapping was done on individual initiatives. Yeah, but it was congregated.
What we can say is we're happy to, if someone wants to, go more into detail or just wants some assistance in any kind, thinking about implementing something like this, we're happy to answer questions. So you can contact us by email or even by phone if you're not too far away.
Hoy en día todo queda muy cerca, ¿no?
Nowadays everything is so close. We have some questions. Maybe they're just slipping a little bit away from our context. In Mexico and Egypt, they speaking about the problems they have with drug trafficking, and they're asking for answers on how to deal with this. What specific recommendations we could give towards the situation of drug trafficking. I don't know, maybe Real, Wadih can provide an answer, or any of the other speakers.
You should start first. I think so.
I'm sorry, I'm trying to alternate. I have the interpretation on my phone. So, yes. Drug trafficking, I mean, supply reduction measures are a component of prevention, but they cannot resolve the problem. When we're saying demand reduction services in terms of prevention, like we're talking about, the supply reduction is a component, which is like related to accessibility. But regardless of how much supply reduction measures are put in place, and how much efforts are put in place to cut down on the availability of illicit substances or misuse of licit substances, the vulnerability remains there in terms of person. And there are the substances that we're describing are not necessarily substances under international control. So that's why, in my own biased opinion as a person working on prevention, we always incite the availability of prevention services like we're talking about, because they, regardless of whether or not the substances are in the market and what substances we are discussing, will address that vulnerability that leads the person to engage in any risky behavior. So even though we need a balanced approach, and one does not dismiss the other, but to a large extent, prevention measures especially in the context of availability of substances, availability of cheap substances, accessibility to these substances, prevention efforts are needed more than ever. This is what I will try to focus on, because as you saw, everything I mentioned is substance neutral. I did not prevention of synthetic drugs, prevention of opioids, prevention of, because we're trying to prevent the risky behavior from happening. And I think that resolved a lot of the issues that are of concern for the national counterparts.
Maybe I would also add that as civil society organizations working on the field on prevention, treatment, recovery, we are more focused on drug use prevention in this regard. But still, for instance, if we look at this Oviedo's Declaration initiative, we got a lot of requests from countries, even governments, that are facing with drug trafficking, like Ecuador or Honduras or these kind of countries, but not only asking for short-term solutions, but long-term, because there is an understanding, although in the policy-making logic, sometimes it is more, it comes first, the short-term solutions, but they can understand that if you really want to overcome big problems like this one, you have to invest in other strategies like prevention. So I think we are discussing with a lot of organizations, even governments, in this in this approach, in the long-term view. So that means probably investing in strategies like prevention.
Ciertamente. Gracias.
Certainly, and thank you, Wadih and Ariel. That question wasn't easy, and the solution apparently is not either. We have one last question. We still have 6 minutes. This is for Yvonne and Alexander in relation to the implementation of REPS. And they're asking if the process identified any harmful intervention or ineffective intervention, and in that case, how was it approached?
No, we really didn't find any harmful ones, actually. But we also, there were some of the interventions, they were categorized as, of course, many of them are non-evidence-based, and some of the non-evidence-based can potentially be harmful, but not as such that we find it very serious. And we have a very the country is small, and the local and the regional professionals, they also have a very close eye on what's happening in the schools, etc. So yeah, if that was an answer, do you have anything to?
Yeah, I think it's interesting how the response to the report. They're very curious about, how did our strategies, how were they assessed, and they want to know that they're actually doing the things that work, and not wasting resources. So I think there's been a very constructive, curious, and positive response from the different regions.
But we also have discussed this a lot with the other choruses, because they also address this as a kind of a barrier or something interesting that maybe the people out there knowing, especially when it comes to the private initiatives, because they don't have to, they can do whatever they want actually, and they will stay away from choruses, because they know that when it comes to their substance use prevention work, we will give guidance, and we will tell them to stop doing this. But we actually met I met one lady at a conference. We were having a stand, and she asked me about some local initiative, and she said, now I realize that we have to stop doing this because what we are doing, that is harmful. And I talked to other professionals and policies, and they said exactly, they say, you have all given the same answer to my question. So at least we can see that for those of them are reading the report, and they will stop doing this. But of course, the others we don't know. We have no knowledge about them.
Thanks a lot, Yvonne and Alexander. And I think the time has come. Now we're going to have to end our meeting. Thank you for your participation, to all the speakers, Alexander, Yvonne, Natalia, Wadih, Livia, Victor, all the speakers. And I would like to remind you that this webinar is going to be uploaded on the web, and those who have registered, you're going to receive a link in between 24, 48 hours. Sorry about the translation. It is a bit complex. It is not that easy to set it up, and we would love to see you again in the next webinar or during the next encounter in person in Greece. And Natalia is going to host us there with their arms open. Thank you all, and I hope to see you again soon.